Hello, everyone, and welcome to today's live broadcast, Emerging Diagnostic Strategies to Support C. difficile Infection Control, presented by Dr. Liat Peterson, past Director of Microbiology and Infectious Disease Research Program, past Director of Medical Microbiology Fellowship, and current Epidemiologist, North Shore University Health System and Clinical Professor, Pritzker School of Medicine, University of Chicago. I'm Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is brought to you by LabRoots and sponsored by Roche Diagnostics. Let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question and click on the Send button. We'll answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, click on the arrows at the top right-hand corner of the slide window. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Answer a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I'd like to now introduce our presenter, Dr. Liat Peterson.
Thank you very much for the kind introduction, and thank you for joining me. This is a topic that is of current interest and changing quite a bit. The laboratory ends up being right in the middle of all of the diagnostic and prevention measures, and we're going to talk about that today. First, these are my potential conflicts of interest. Over the years, our group has done studies with many industry groups as well as the government, and we've gotten research grants from them. I continue to do some consultations for the groups mentioned here on the slide. And again, a reminder, this presentation is sponsored by Roche Diagnostics, so we will be talking about some of the new products that they have that fit into the solutions for this particular problem. What I'd like to talk about today is a little bit of the disease overview for Clostridium difficile, and the role of diagnostic and testing options, and then understanding some of the C. difficile epidemiology, which continues to evolve and we continue to understand better. We'll talk about some new approaches to Clostridium difficile infection prevention, and then how to optimize the C. difficile testing workflow, and what time frames really have led to improvements in prevention for this kind of infection. First off, what is C. difficile in the acute care setting? And basically, it's new onset diarrhea, and that's what we want to really focus on when we're trying to decide who we need to test. So we're looking for new onset diarrhea after hospitalization or at the time of hospitalization, where there's really no other explanation as to why the patient might have diarrhea. The epidemiology is interesting. This particular slide shows that since 2000, there's been a slow increase in the rate of Clostridium difficile in hospitals. And you can see that it started at around 5 cases per 1,000 discharges, and by 2011 really had gone up to about 12, and the projection was that it would continue on into the future. The number 5 is actually a little bit above where we'd like to be for even a low-level endemic rate, which most experts seem to want to keep under 3 cases per 1,000 discharges. So you can see that the progression of C. difficile has gotten us into a very high rate nationally in the United States. This is the more recent data, which really demonstrates that the projection has been accurate. You can see that the total cases per 1,000 persons has actually increased since 2012 through 2015, and we're both seeing somewhat of a decrease in hospital onset cases, but this has been accompanied by an increase in community onset cases. We'll talk more about this later, but we need to be aware of this because if people are acquiring Clostridium difficile in the community, then we have to be very careful about what antibiotics are given after they're hospitalized. So what's happened? In the past, Staphylococcus aureus has been really the number one hospital onset infection that has been acquired as a result of hospitalization. Clostridium difficile has now overtaken that, and you can see that really beginning in the late 2000s, 2008, 2009, the MRSA was exceeded by Clostridium difficile by about 25%. It's important to understand that Clostridium difficile rarely colonizes the intestines of healthy individuals. Generally, 3 to 5% of community dwellers may have C. difficile that you can culture from their stool, but it doesn't persist, and it's only a transient colonization for a few weeks. In hospitalized patients, the rates may be as high as 20% or more. It is an expensive healthcare-associated infection, and the excess costs are nearly $6 billion a year in the U.S. What has been typical over the years for Clostridium difficile is a new strain would appear that would go into the hospital and persist for a few months and then really be replaced by another new strain. The Clostridium difficile strain, the BI or NAV1027 strain, has really persisted in the United States, and in some settings it's been hypervirulent and also multi-drug resistant, including resistance to the fluoroquinolones. So this has really been a change in the epidemiology of this organism with this century. One of the questions that's important is, how does Clostridium difficile cause disease? There are two large clostridial toxins, toxin A and toxin B, that are the main virulence factors. Toxin A is an enterotoxin that stimulates release of cytokines and really leads to fluid collection in the gut. It's very immunogenic, so some of the early immunoassays really focused on toxin A, but the problem is there are some strains that don't produce toxin A and only produce toxin B that still cause disease. Toxin B is a well-known cytotoxin that increases the permeability of the gut wall and actually disrupts the actin cytoskeleton that is what gives the structure to the colonic cells and causes them to collapse, leading to diarrhea, cell death, and cell sloughing. And so toxin B is generally considered the main virulence factor, and toxin A works with toxin B to make disease worse. It has a wide range of clinical disease. As you can see on this slide, the usual symptoms are diarrhea, and Clostridium difficile infection used to be called Clostridium difficile diarrhea, because that's the main symptom that or sign that is seen when you have this disease. And generally, the definition has been at least 3 bowel movements per day for 2 days or more. The definition has slowly moved to 3 stools or more per day for 1 day because hospitalizations have become shorter and shorter over the years. Often there's fever, nausea, abdominal pain or tenderness, and the worst disease then is colitis or pseudomembranous colitis that can occur in patients and often causes disease throughout the entire colon. It's important to keep in mind when you're in the laboratory and looking for who to test is that we don't normally look for asymptomatic colonization of this organism because about 10 patients are colonized for each one with disease. So if we're actively looking for colonized people, and those are the ones we're going to try to treat, we will way over-treat and over-diagnose this disease. This, of course, makes the testing and diagnostics much more challenging because we really need good partnership with our clinicians so that they carefully look at who should be tested and not just send stools for people that have diarrhea for other reasons. It's not laxative-induced diarrhea, so generally You want patients that have been on a laxative and have diarrhea to have the laxative stopped before they have their testing for C. difficile to make sure that the diarrhea persists in the absence of laxatives. And this is just a schematic with a photo of what the pseudomembranous colitis looks like if you do colonoscopy on these patients. And you can see the little nodules, and that's very typical of what the gastroenterologist will see when they stick a tube into the colon and take a look at the mucosa. The outcomes with C. difficile seem to be getting worse as well, and as you can see on this slide, they are quite poor, and the risk of recurrence is between 12 and 64%, depending on the series, with an average of about 22% of patients having at least one recurrence. Complicated Clostridium difficile infection can occur in 15% of the patients and up to 50% depending on the population. Treatment failure has gone up as well. In the past, it used to be about 3 to 5%, and now it's up to 50% in some series with an average or median of 21%. And then mortality, the risk of death is between 8 and 53%, which is also quite a bit higher than it was before this century. In general, in the past, mortality was associated with C. difficile infection about 1 to 3% of the time. So you can see that this is a disease that is apparently much more virulent than it used to be, and something we really want to try to prevent in our patients. The current testing for C. difficile infection generally still revolves around either culture or immunoassay, and then the new way to diagnose this is a nucleic acid amplification test represented in the middle, and these have been generally available for the last 10 to 12 years. The up-to-date article, which lead author is Cliff McDonald from the CDC, is a very good reference for this. The citations or references are updated every month, and this is the current recommendations in that early diagnosis is one of the important aspects of this, because we want to have early detection and use contact precautions with patients that have suspected or proven Clostridium difficile infection. The recommendations are to continue contact precautions or isolation at least until the diarrhea has ceased, and many hospitals will continue it until the patients are discharged. In up-to-date, it suggests using washing with soap and water as a better way of removing the Clostridium difficile spores from your hand. Alcohol does not kill the spores. We'll see in a minute that the new guideline from the Infectious Disease Society of America really ranks either of these as equal, but hand hygiene is very important to make sure we don't spread this organism around the hospital. Environmental cleaning and disinfection is critical, and it does require a sporicidal agent, and most places will be using some form of bleach to do that. Recommendations are to use disposable medical equipment. Some of the new things that are being tried, with the impact not certain yet, are ultraviolet light decontamination of environmental surfaces, routine chlorhexidine bathing of patients, and then admission surveillance or detection of carriers. This is the new Infectious Disease Society clinical practice guidelines that have just been published. And the strong recommendations with either high quality or evidence or moderate quality evidence are on this slide. And you can read through them. You can see that most of them deal with infection control practices or treatment of patients. The one that's pertinent to the laboratory here is that patients with suspected Clostridium difficile infection should be isolated at the time the order is placed unless the test is done in less than 24 hours. So if you're doing a rapid test and getting the results back in less than 24 hours, you likely can only isolate the positive patients. But if it takes longer than that for the results to be reported, the recommendation is to isolate the patient until the results are done. This can be used to help justify rapid testing because if you're isolating everyone and only about 15 to 20% of your patients are positive, that means you're isolating 80 to 85% of people that don't need it, and isolation is expensive. The savings in not isolating patients that don't need to be in contact precautions can be applied to more rapid diagnostic testing, and that's how we justified rapid testing in our facilities. This particular slide looks at the new guideline recommendations for clinical practice laboratory testing, and you can see the recommendations are weak and the evidence is low quality, which generally means there's no strong agreement on all of the experts on what to do, and so still it remains up to the laboratory to figure out what is best for their own organization. And generally what is said is if you have an agreement on who should be tested, then you can use a toxin test as part of a multi-step algorithm, or you can use a nucleic acid amplification test as part of the algorithm. If there is pre-agreed criteria, then a nucleic acid amplification test alone can be useful because it's a very strong way of telling who really doesn't have Clostridium difficile infection. This is an interesting article that was published 2 years ago. Agency for Healthcare Research and Quality, or AHRQ, is responsible for the government assessment of outcomes in the United States. And this is a clinical effectiveness review that they sponsored. And if you read through it, you can see that the nucleic acid amplification tests have the highest evidence with their outcome for testing, with very high sensitivity and high specificity. And the comment in this particular paper that a negative algorithmic test is the least effective strategy to decrease the probability that a patient has clinical Clostridium difficile infection. What that means is that the nucleic acid amplification tests are the best way to tell if somebody really doesn't have infection. There's an argument that some are making that the tests are too sensitive and picks up carriers, and this is really a confounding issue for the laboratory and has made it difficult to come to consensus on what to do. But clearly, it's the most sensitive rapid test for ruling out this particular hospital infection. This is an article that was published, again, it's a critical review published in 2017, and they reviewed 11 commercial assays where there was published data on their performance, and these were all nucleic acid amplification tests. And the Roche assay was not part of this review because it had not had the data published as yet. But there were only 3 of the available commercial tests with consistent sensitivity and specificity above 90%. At the time, that was the Cepheid Expert test, the Portrait Toxigenic C. difficile test, and the Illumigene C. difficile test. The other nucleic acid amplification tests had sensitivity or specificity, or both, less than 90%. This is the performance of the Cobas 4800 test for Clostridium difficile infection, and you can see this was published after that last article that the sensitivity is over 90%, specificity is almost 99%, negative predictive value almost 99%, and the positive predictive value was 95%. So again, this fits in with the other NAT tests that are over 90% sensitive and over 90% specific, and so would be considered as part of those tests that have performed the best. And this is the Liat. This is data from Europe that has recently been published, and looks again very similar to the Cobas 4800. You can see the sensitivity for both is over 90%, specificity over 90%, and the overall percent agreements 95%, negative predictive value 99%. So this particular test is approved by the or cleared by the U.S. FDA, but is not quite available for use in the United States yet. But we should anticipate that it has very similar data or very similar performance to the Cobas 4800. And this is what the Cobas 4800 looks like. It's an automated testing platform with basically sample in and result out, primary and secondary tube loading. It's less than 30 minutes setup for a full run of 94 samples. And we have used it in our research laboratory and in our clinical laboratory processing. It's very simple. And this is more about the particular test on the Cobas, broad range of both the toxinotypes and ribotypes, which are just various terminologies that are used for the various genetic types of Clostridium difficile. And it has very broad coverage, including the hypervirulent strain, the BI, NAP1 or 027, whatever is being used for the terminology. And this is the Liat system. The Liat is a very small instrument, about the size of a blender, and it does one specimen at a time, and the results are available in 20 minutes. So basically, the swab goes into the machine. 20 minutes later, you have a result. Right now, it's available for influenza A, B, and influenza with RSV, and then strep group A. As I said, it's been approved or cleared by the Food and Drug Administration of the United States, and but not quite available for use as yet. What about the Clostridium difficile infection epidemiology? I think this is where there's been considerable interest, and we've learned a lot very recently. This is a hospital that had new construction in the Chicagoland area. In a minute, I'm going to show you a video, but basically what was looked at was different buildings, and the Clostridium difficile infection all occurred in the adult units. And in the video, you'll see covers about a year and a half, and green dots are patient room, blue dots are patient rooms where there are C. difficile patients over this year and a half, and gray dots are miscellaneous rooms. When you're looking at it, I want you to see if you can envision any pattern of where the C. difficile patients are showing up, and we'll look at the video now. Well, I've looked at this video many times, and I can't see a pattern, and no one else has been able to see a pattern. So if you couldn't see a pattern, that's the right answer. And what this means is that C. difficile really requires a comprehensive plan for your healthcare setting. It's not the same as an organism that the same organism is spread from patient to patient, or from a point source, if you will, where there's a contaminated sink or a contaminated part of the hospital. But generally, it's a disease that can pop up in patients almost anywhere. So we need to consider that as we're planning our strategy for lowering this infection. This is another article that looks at the same thing, and what they're looking at is patients with CDI that have toxigenic strains that were positive in their stool, but the direct toxin test was negative, and how these related to transmission. And what they found was that about 3 times more patients were likely to transmit the disease if they had both toxigenic strains in their stool, as well as their stool was direct toxin positive, rather than if their stool was direct toxin negative. But the direct toxin negative patients were actually significant contributors to transmission in the hospital. And as you recall from the earlier slide, there's about 10 times as many toxin negative, direct stool negative patients that are asymptomatic that are in the hospital than are those with disease. So both groups are thought to be important infection control targets at this point, both the asymptomatic as well as the symptomatic patients. And this is another slide looking at a little different aspect of this, but coming up with very similar conclusion that a few cases of the CDI infection are acquired from other patients, but most appear to be activation of carriers that were present on admission or new transmissions from asymptomatic patients, which means that we need to look at new approaches, including screening and universal gloving rather than typical infection control tracking, use of more sporicidal cleaning methods to clean up our environment, and then particularly avoiding drugs. The clinicians need to avoid drugs like extended spectrum cephalosporins, quinolones, and clindamycin in patients that have Clostridium difficile colonization so that they don't progress on to infection. And this is another study looking at the same thing, looking at the dynamics of how patients get colonized by the hospital and vice versa. Again, this was a new hospital. This was at the University of Chicago after they opened their new hospital. And they looked at what happened to patient flora and room flora. And when patients first went into the room, they actually acquired what was on the surface of the room. So they acquired the room flora first, and then later in that first 24 hours, they started contaminating the environment, which I think is important from the standpoint that we have to pay attention to patients when they are colonized with an organism like this, but we have a little bit of time to figure it out before they heavily contaminate their environment. And this is, again, looking at our data. We're looking at the kind of PCR, or the kind of Clostridium difficile that patients are colonized with. And if you look down at the bottom, 9 out of the 12 patients that had Clostridium difficile infection after coming into the hospital had pathogenic ribotypes. So there are certain strains of C. difficile that are more likely to cause infection than are others, and it is going to be important, I think, as we move forward to do a better job of genetic analysis when we ascribe risk of disease from transmissions, and this is currently challenging because this requires a lot of work. So what about admission surveillance for Clostridium difficile infection prevention? This has been talked about really for a few years, but not much has been done until recently. In 2001, perirectal swabs were amplified with a laboratory-developed test and actually were found to have good sensitivity and specificity for detecting the strains in stool. Then the glutamate dehydrogenase enzyme fluorescent antibody test was looked at and compared to the nucleic acid antibody test, or nucleic acid amplification test, for detecting asymptomatic colonization. And as expected, the NAT test was better in sensitivity than the GDH test. And then finally, a Canadian study looked at what happened if they did admission surveillance, and this was done in the emergency department, and so they knew what patients had Clostridium difficile colonization. You can see they had a 57% reduction in their cases, which was statistically significant. And this is really the first study to show that admission surveillance might be useful and was able to clinically impact the patients that were having disease. And there's probably two reasons for this. One is that you know who is colonized to try to prevent transmission, but you also know who's colonized so you can be more careful on what antibiotics they are prescribed. So we were looking at whether this might be helpful for us, and we have looked at the impact of rapid Clostridium difficile infection diagnosis, room cleaning, hand hygiene, UV disinfection, and finally real-time PCR admission screening over the last several years. And the screening seems to have had the most impact. We did a pilot at two of our hospitals. One of the hospitals used the expert test that we did not have enough compliance with the testing, so we couldn't analyze it. But the other hospital used the cobas 4800 test and found a significant reduction in clinical infection from Clostridium difficile infection. We found that significant risk factors for colonization, including recent hospitalization, systemic antibiotics, past C. difficile, and long-term care within 6 months. And so we actually have started targeting C. difficile screening in all of our hospitals. That began August 1st of last year. We looked at the performance of the test, of the cobas test in our hands. This is an off-label use of the assay, so you have to do a validation of it, and this has just recently been published in Journal of Clinical Microbiology. We tested 1,803 samples, and you can see that the estimated sensitivity was between 95 and 100%, specificity 98%, with very good positive and negative predictive values. So this basically is a test where the patients get an intraanal swab, and that swab then is tested directly on the cobas 4800. And this is our results to date. As I said, we tried multiple other interventions, and the compliance with each of these interventions really didn't correlate with whether we had higher or lower numbers of Clostridium difficile infection rates, and nothing really correlated until we started doing the admission testing. And in the year before we started this, the overall case rate was 6 cases per 10,000 patient days. Looked at the first 6 months data, and in 3 of the 4 hospitals, we've seen a 33% reduction in the Clostridium difficile infection rate from 6.44 to 4.29 cases per 10,000 patient days, and this is statistically significant. The one hospital with no improvement had a testing compliance under 60, and they've been working on this, and it's now up near 80%, so we'll see if that helps in the improvement going forward. And they also had a very low baseline rate of 4.6 cases per 10,000 patient days, and this then has made it more challenging to show a difference, but we will continue to follow this and see if the rate goes down. Or we'll talk about this a little bit more, but our goal is to get the rate down below 3 cases per 10,000 patient days at all 4 hospitals. And this is just a graph of what's going on. All 4 hospitals are graphed in the more thin lines, and then the overall mean of disease is in the thicker line. And it's hospital 3 that is the one that hasn't had a reduction, but you can see it started out at a very low rate to begin with. So how can we optimize the workflow for managing of Clostridium difficile infection? I think it's important to understand the biology a bit of this particular organism. And from an infection control standpoint, organisms really spread and cause problems either by evolving in a panmictic way or a clonal way. And what I mean by that, clonal evolution is where the organisms don't change a whole lot, but they're very good at spreading. And these are organisms like Staph aureus and Mycobacterium tuberculosis. Clostridium difficile is in that same group, so that tends to be on the left end. On the right end, these are organisms with a relatively malleable genetic background, and so they can continue to mutate under pressure of antibiotics, and you'll see resistance continue to evolve and change. And that so stewardship becomes really the main answer, how you're using antibiotics for controlling these panmictic evolving organisms. But clonal evolution, where spread is important, is really the infection control isolation practices that helps control their spread. And how does one become infected? Well, MRSA is a good model for this, and this is data from our MRSA program looking at nearly 200,000 patients. And if you look at patients that have either colonization by PCR and culture, or just a positive nasal test by PCR but no positive culture in their nose, versus no MRSA in their nose at all, being colonized with MRSA really increases your risk of infection more than tenfold. And this is really the same thing that we've seen with Clostridium difficile. The first step to getting this infection is to become colonized. So what you want to try to do is to prevent spread of colonization of these organisms to new patients. If you can do that, you can really reduce the rates. And this is just a slide of our MRSA control program where we've done admission screening and then isolation of positive patients. And you can see the rates for disease went down very quickly after it was started. Within a year, we had a 70% reduction in disease, and we're down below now 3 cases per 10,000 patient days. We're getting close to that with our Clostridium difficile infection control program, and this is the goal we set for us, because we do think that these two organisms behave very similar biologically in how they spread in the hospital and cause disease. So if you're going to do rapid testing, how rapid does it have to be? And this looks at, again, Staph aureus or MRSA either by culture, and the top is traditional culture or chrome agar culture. The middle curve is using broth enrichment, and then the bottom curve is real-time PCR. And we're looking at the sensitivity of the test and then the time to detection. What we found for MRSA is that control is based on how much of the time these patients are in the hospital they're actually in isolation. And so on the vertical axis, we're looking at the percentage of isolation days that are missed. And if we look at the lower curve, we discussed early on how quickly we needed to do our PCR testing. We do batch testing for MRSA, and that average turnaround time from ordering of the test to receipt of the result is 15 hours. And we asked the question then, what would happen if we did the testing on every shift and got the time down to about 6 hours? And you can see we only went from missing 15% of isolation days to 10% of isolation days. We didn't think that was really significant, and it hasn't been. So 15 hours has been fine for MRSA. It doesn't, the curve doesn't go to 0 because the sensitivity is not perfect. But if you make these curves perfect, you can see that even going to 6 hours, you'd still only get down to 5% of isolation days missed. And that didn't really think from a practical standpoint was important from the standpoint of improving our control, and it wasn't. Really, the optimal testing for direct culture and reporting, you'd miss about 40% of isolation days, and using broth enrichment, you'll miss about a little more than 40, almost 45% of isolation days. So if you're using an insensitive test, what this says is that it's very difficult to get the control you need because you can't get people into isolation quick enough. So what are the options for molecular testing of Clostridium difficile infection patients? And I think if hospital practice is isolate upon order, then daily testing is really sufficient to control your clinical infection. If the practice is to isolate after a positive test result, then you probably need rapid testing of samples so that the result is back to the patient in less than 24 hours. As you recall from the earlier slide we looked at, first the room contaminates the patient, but by 24 hours the patient starts to contaminate their environment. So we need to know who is harboring this organism in order to really reduce the environmental contamination. There's really no evidence for superiority of either practice, but the isolate upon order, if you can avoid 80 to 85% of your isolation, the isolate on order ends up being more costly from a standpoint of isolation practices, isolation equipment, and isolation after a positive test. If it's a rapid nucleic acid amplification test, the testing may be more expensive, but the actual overall program is cheaper because you don't isolate nearly so many patients. Admission testing for surveillance testing to detect colonization is still a challenge. We are proceeding forward with ours because we have had meaningful results in the first 6 months. It does look like mean time from collection to reporting of under 16 hours is useful. It's sufficient for MRSA control and likely applicable to Clostridium difficile infection. We test once a day, 6 days a week. So we're doing Monday through Friday and Sundays. Excuse me. And that seems to be having an impact. And there is a wide range of test platforms that are available now for Clostridium difficile that the laboratory can choose that really fits best with their workflow and their cost. So in summary, Clostridium difficile infection really is the new challenge for U.S. healthcare. Nucleic acid amplification testing offers the best sensitivity to detect toxigenic C. difficile, and a negative test really is the best indication that there's no disease present from this organism. But not all assays are equivalent, so you do need to look at the test performance as to especially sensitivity and specificity. The role of active surveillance testing at the time of admission is evolving, and as more people look at this, we'll have a clearer picture of to whether this is useful or not useful. And the opportunity to optimize the workflow based on turnaround time requirements and volumes of testing really exists with current platforms, and there is a wide range of testing opportunities that the laboratory can use. So at this point, I want to thank you, and we'll open it up for questions and hopefully some answers. Thank you very much.
Thank you, Dr. Peterson, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, can you describe your overall C. difficile infection control program?
So for us at North Shore, we do rapid on-site testing. We have 4 hospitals, and we're using the expert test for clinical diagnosis, where the test is done 7 days a week, 24 hours a day. And because of that, we don't isolate on order, but we only isolate when the patients have a, a positive test. We also, for several years, as I mentioned during the talk, have been doing different practices, including using UV light decontamination, monitoring of how well the rooms are being cleaned by our environmental services, bleaching the rooms after the patients are discharged, the ones that have had Clostridium difficile infection. And we really have not been able to associate any of these practices with a reduction in disease. If a practice compliance is high, it doesn't necessarily correlate with a low C. difficile infection rate for that given month. So our sustainable trend in downward infection has started since we did the admission screening, which probably makes sense because we do know most of the patients. We're capturing about 80% of the patients that are colonized with Clostridium difficile when they come in the hospital this way, and so we are able to restrict the environmental contamination and spread of this disease. We do the admission screening testing at the Central Hospital at Evanston Hospital, and that's run once a day, 6 days a week, Monday through Friday, and then again on Sunday using the Cobas 4800. And we found that this is what was used in the pilot. That we had a successful program at one of the hospitals, and we've continued that. So it does appear that the control of C. difficile from an environmental contamination standpoint and spread to other patients standpoint is very similar to that of MRSA, that you can do it on a batch basis once a day, and in that way get the patients that are colonized into isolation as soon as possible.
The CDI infection control program sounds expensive. How do you justify that cost?
It's relatively expensive, but we've estimated if we are able to reduce the Clostridium difficile infection rate by about 50 to 60%, we'll break even. Higher than that, we'll actually be ahead in reduced costs for taking care of Clostridium difficile infection patients. They're relatively expensive and add between $8,000 and $10,000 per patient to healthcare costs just in the hospital alone. So similar to MRSA, if you can reduce these preventable infections, you actually are able to save expenditures for the hospital. The other thing with both MRSA and Clostridium difficile, they're called HACs, which are hospital-acquired conditions, and Medicare fines hospitals for these, and the fines can run over $1 million a year. So, yeah, if your hospital is exceeding the threshold that's given to them by Medicare and Medicaid services or CMS, you'll not only have the added expense of taking care of the patients that develop infection, but of the fines from the Medicare program. So there's quite a potential to actually come out ahead and save money by efficient and effective control of Clostridium difficile infection.
Dr. Peterson, what is the rationale for repeat testing in 7 days? Is the repeat testing in known positive patients or those previously negative?
How this 7-day period came up was that in the past, when enzyme immunoassays were used, it was known their sensitivity wasn't good. Physicians would often do repeat testing until they had a positive result. And I've given lectures to gastroenterologists and gastrointestinal surgeons and asked them how often they test for C. difficile, and this is in the past. They say, well, they tested until they got the right answer. And all of these tests have a small false positive rate. But after really the first test, you've eliminated most of the true positives, and with an enzyme immunoassay where your sensitivity is around 50 or 60% for toxin detection, you have more false positives with the second test than you do with the first test. So the rationale is now to do a good test right at the beginning, and then not test again for at least a week, even if there's persistent diarrhea and you've had a negative test. With the rationale for that being that the second test is more likely to be a false positive than a true positive. Clostridium difficile is not a normal flora in humans, so you're transiently colonized with it, but the transient colonization will last a few months, 1 or 2 months if you don't receive treatment. So there's no reason to test, if you have a sensitive test, to test more often than once a week during the same episode of diarrhea. And we do not recommend retesting unless there's a new episode of diarrhea after the first episode has resolved. So the rationale has just been to avoid all these false positives by stopping doing repeat testing. And in fact, we used to do repeat testing using enzyme immunoassays, and our overall rate actually went down when we went to testing using nucleic acid amplification test, but it would only do it once per week as a maximum because we avoided all the false positives.
Our next question is, so you are saying a NAAT test alone is sufficient to accurately detect CDI, of course in congruence with signs and symptoms. I did not see diarrhea as a symptom for admission testing.
Well, most of the people that come in with new onset diarrhea will have had antibiotics as an outpatient, so you don't have to have the antibiotic prescribed in the hospital. It can have been obtained from your community physician, and you develop C. difficile infection at that point. So regardless of whether your new onset diarrhea occurs in the hospital or in the community, the criteria are still the same. The only difference is that you have to be in the hospital for more than 2 days in order to have it be considered a hospital onset infection, which is what the HACs or the hospital acquired conditions are that are fined by Medicare. So the criteria are the same whether it's an inpatient or an outpatient, and actually about half of our testing, or maybe even a little bit more than half of our testing, is currently on outpatients.
What was the intervention for patients testing positive with the screening test?
So if someone is tested positive with the screening test, they go into contact precautions, and they're treated the same way as if they have clinical infection or Clostridium difficile infection that's clinically giving them diarrhea, and they stay in that contact precautions throughout their hospitalization, and then they're retested when they come back. If they're readmitted, if their test is negative, then they would come out of contact precautions, but if it's positive, then they would remain. So our Clostridium difficile infection screening program and the MRSA screening program are basically both the same. If you've had a history of a positive test, either from a clinical infection or a screening test, you are tested each time you're admitted, and that admission test drives whether you're isolated or not for that given admission.
What would you summarize are the primary advantages to using PCR exclusively over an algorithm testing approach for C. difficile?
Well, I think over the years, my training is both infectious disease and medical microbiology, so I, in the past, have seen a lot of patients with Clostridium difficile infection that, unfortunately, the laboratory can only tell the clinician whether or not the patient has a toxigenic Clostridium difficile in their stool. They can't really make the diagnosis of Clostridium difficile infection because there's no test in the laboratory to separate colonization from infection. So we've taken the position that we want to have the most sensitive test available for knowing whether or not the patient actually has Clostridium difficile as a toxigenic strain in their stool, and then the clinician has to make the decision as whether there's an infection or not. Unfortunately, this requires a lot of ongoing education of physicians. Taking care of patients is quite complex. They're all pretty sick when they come in the hospital, and so there is this tendency for a positive test to be treated, and we spend a lot of time from infection control discussing with physicians when they order a Clostridium difficile test in the hospital. Do they meet the criteria? Are there no other reasons for diarrhea, like laxatives? Have the patients had at least 3 loose stools a day? Is there anything else? Do they have abdominal pain? Have they had fever? Do they have an underlying inflammatory bowel disease or ulcerative colitis that gives them diarrhea? And we try to, on a one at a time basis, when necessary, educate the physicians to have them think through the process of who should actually have a diagnostic test run for C. difficile. Our colonization rate is between 9 and 10%, and our infection rate is right now running about 4 patients per 1,000 admissions. So you can see that our colonization rate is about 10 or 20 times what the actual infection rate is. And so if you're not very discriminatory on who you're testing, then you're going to have a lot of positive tests in patients that don't have C. difficile. For us, since we're very aggressive on trying to make sure that this organism doesn't spread in the hospital, we also want a test that has a very high negative predictive value, and as that AHRQ quality review paper showed, the best test for knowing that a patient doesn't have Clostridium difficile infection is the NAT, or nucleic acid amplification test.
Dr. Peterson, our next question. Can you comment on those experts who conclude that NAAT-only testing leads to overdiagnosis and overtreatment?
This is, as I mentioned briefly during the lecture, this is an area where the recommendation of what to do was low recommendation based on weak data, And unfortunately, you really need to do what is the consensus is best for your hospital. Again, my own feeling is that the laboratory, the role of the laboratory in this is to tell the physician whether or not there's a toxigenic Clostridium difficile in the stool, and then it's up to the clinician to use their education and their training to actually decide whether this organism is or is not causing disease. There's never been a study that's shown that a less sensitive test is better at separating disease from colonization. Even the British study that Mark Wilcox was a leader on, where they showed that there was some excess diagnostic of Clostridium difficile infection when used a NAT test. There's actually no statistical difference between any of the outcomes between using a NAT test or an algorithm. The only difference was between the algorithm and people with no testing done at all. So I think that the argument still is basically going to be up to each individual hospital to decide whether or not the NAT testing is best for them. In my own personal opinion, like I said, I think the laboratory, our role is to tell the patient's doctor whether or not there's Clostridium difficile that's toxin producing in the stool, and the best test for that is either culture, which can take about a week or 10 days to complete because you have to look for toxin, or the nucleic acid amplification test, which some of the new assays can give you a result in 20 minutes.
Dr. Peterson, this is a three-part question. How do you classify patients who are positive by swab on admission but do not have signs or symptoms of disease? Do you treat them for C. difficile? How do you then define cases of true C. difficile infection to accurately determine cases of either hospital-acquired versus previously existing C. difficile infection for reporting purposes?
So for the first one, we put if they're just screen positive and have no symptoms, they go into contact precautions. They're not treated. We did a study, probably 30 or more years ago, and Stuart Johnson was the lead author on that, where we looked at what happened if you tried to decolonize asymptomatic patients, and it basically prolonged their colonization from about 2 months to 6 months. So we don't recommend trying to decolonize patients with either oral metronidazole or oral vancomycin, because it just prolongs their colonization, and it takes longer for their stool to become negative. For the patients that are positive with symptoms, if the symptom onset is greater than 2 days after admission, then by the criteria of NHSN, they are actually disease that develops in the hospital. So we follow the NHSN criteria for the diagnosis and reporting of C. difficile. NHSN does not count screening tests as part of the reporting function, so you don't have to worry if you do screening that you'll have to be reporting those results to NHSN. It's only the diagnostic testing. So we have a separate test code for screening than we do for diagnosis of clinical infection.
Our next question is, what testing methodology incorporates perirectal swabs for CDI testing?
Well, right now, the perirectal, which means intraanal, because the rectum is actually inside the anus, so you do want to get the swab, basically the little white part at the end inside of the anus. None of the tests are approved. The test that was used in Canada in the study where they showed a benefit was the expert, but there was no analytical validation of that in that particular paper. The reason we published our paper that I mentioned in this report was, again, there's no FDA cleared test for the Cobas 4800, but we wanted to validate it because we wanted to do the screening test, so we validated the assay in our own laboratory. I've actually corresponded with the Food and Drug Administration on this, and they were fine with that. They said once the test is cleared, physicians have a broad range of what they're allowed to do with the test, and as long as we've validated the assay in our laboratory, that they would not take any action to stop our laboratory from using the assay.
And Dr. Peterson, it looks like we have time for one more question. Do you consider it economically justifiable using vancomycin or fidaxomicin in the initial management of toxin-negative but severely symptomatic DGH-positive patients?
Oh, the GDH, yeah, it's glutamate dehydrogenase. So about 20% of the C. difficile strains will be positive by the GDH assay, and that's because it's part of their cell structure, and they don't produce toxins. So we would not recommend using either fidaxomicin or vancomycin in a patient that was toxin negative. Now, it depends how you're doing the toxin test. I think that the enzyme immunoassays for toxins have a sensitivity in the 60 to 70% range, so you could miss them. But if you're doing a GDH screening and then you have a negative PCR test, I think that's pretty good evidence that you have a non-toxigenic strain. It would be unusual to have both toxigenic and non-toxigenic strains present in the stool. I suppose it could happen, but it would be very unusual. So if I was doing screening with a GDH test, had a positive test, and then had done a PCR test and it was negative, I'd look for another reason for the diarrhea, and our gastroenterologists are pretty helpful in that. They've agreed to actually do colonoscopy on patients where there's a question. It doesn't come up very often, but I think what you'd really want to do is rather than treating for a disease that you probably don't think is really there, you'd get some help from the specialist and have the gastroenterologist either examine the patient or do a colonoscopy.
Thank you again, Dr. Peterson. Do you have any final comments for our audience?
I appreciate the opportunity to talk about this. This is an interesting disease that I've been working on since early in my career for probably 40 years, and it still continues to emerge. It is really a challenge, as you saw early on in the presentation. This disease is not getting better. Illinois requires reporting of this particular infection, and I think the data that's available online, if you Google the Illinois report card, you can look at the data through 2016, and you can see even in Illinois that the rates are continuing to rise. MRSA rates are slowly either leveling off or going down in Illinois, but C. difficile continues to go up. So I think that this is going to be a disease that will involve the laboratory for years to come, and it's important for the laboratory to be involved in the control efforts along with infection control.
Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Just a reminder, any questions we did not have time for today will be addressed by the speaker via the contact information you provided at the time of registration. We would like to thank LabRoots and our sponsor, Roche Diagnostics, for underwriting today's educational webcast. This webcast can be viewed on demand through September of 2018. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.